Hi guys, this is Dr. Patil and welcome to this rheumatology module on prep and NETSS. Today we will be learning about small vessel vasculititis. Now, when we talk about small vessel vasculititis, primarily we will be talking about major small vessel vasculititis conditions like ANCA-associated vasculitis and immune complex mediated vasculitis. Okay. Now, before we start with the topic, I do agree that there is a slight delay on my part to come out with this video module. I was kind of under pressure from the students saying that, sir, please come out with this video module, but I was hanging on. The main reason why I was hanging on is I was anticipating major changes in terms of classification criteria and management algorithms for some of these particularly ANCA-associated vasculitis conditions. Because rheumatology is an ever-expanding science and we have seen a lot of changes in terms of our understanding of molecular basis of the disorders, as well as because our molecular basis, understanding of the molecular basis is becoming sound, right? We have also started identifying potential targets for management, and target specific drugs are being developed, and as these drugs become validated in clinical trials, they start becoming incorporated into the routine management guidelines. So our management guidelines are ever evolving. In fact, it is so rapidly evolving that even professional guidelines find it tough to kind of catch up with what is happening in the science world, right? Okay, so when we talk about small vessel vasculitis, the classification criteria that we were following was from 1990 ACR EULAR. So we were hanging on with that classification criteria for more than 2 decades now, and more than 2 decades, close to 3 decades now. And one important thing was that if you look at any of the standard textbooks, they don't talk about this classification criteria because they're kind of outdated. They were based on our understanding of the small vessel vasculitis conditions 3 decades ago, right? So none of our standard textbooks talk. But now the next edition of Harrison, I'm certain that they will start talking about the updated classification criteria, because the updated classification criteria that came this year 2022 incorporate our understanding of the disease, right? So today's lesson will be focusing on, or it will encompass ACR EULAR classification criteria for ANCA associated vasculitis from 2022 recommendations. And for management, we will be following again ACR EULAR recommendations, which is a bit different from your current edition of Harrison. This update came in 2021, right? Okay. Now, the first thing we have to address among the small vessel vasculitis conditions is its classification. So, as part of your Chapel Hill nomenclature system, we classify small vessel vasculitis conditions into two broad groups. The group number one is ANCA associated, and the group number two is immune complex mediated, right? So the examples for our immune complex mediated are anti-glomerular basement membrane disease, anti-GBM disease. Then we have cryoglobulinic vasculitis, and then Henoch-Schönlein purpura, which is today considered as IgA vasculitis, right? So we no longer follow that HSP as the eponym, we call it as IgA vasculitis. Then we have this hypocomplementemic urticarial vasculitis, what we also call as anti-C1q disease, right? These are the examples for immune complex mediated. So today mainly we will be discussing about cryoglobulinic vasculitis from this side of the table. Now coming to this ANCA associated vasculitic conditions, right? So here we have this anti-neutrophil cytoplasmic antibodies positivity, and three classical examples that we all know is microscopic polyangiitis. Then we have granulomatosis with polyangiitis, which in the past we used to call it as Wegener's granulomatosis, right? We no longer follow that eponym. So current accepted nomenclature is granulomatosis with polyangiitis. Then another entity that belongs to the same class is EGPA, eosinophilic granulomatosis with polyangiitis, or also called as allergic granulomatosis with polyangiitis. The most accepted nomenclature is EGPA. And we should remember that in the past we used to call this entity as Churg-Strauss syndrome. We no longer follow this eponym. Currently accepted nomenclature is EGPA, right? EGPA is the most commonly used term today. Okay. Now these three are ANCA associated vasculitis, which are more of a systemic vasculitic conditions, but sometimes ANCA associated vasculitis can only affect small vessels of the kidneys. In that case, we call it as renal limited vasculitis, right? Okay. Now, as I've already told you, our primary focus for today's discussion will be these three entities, MPA, GPA and EGPA, because MCQs are very commonly asked from those topics, and in fact we have to also distinguish between these three entities, and we will also be learning a little bit about cryoglobulinic vasculitis. The HSP is one thing that I would recommend you to watch from the pediatric section of the app, right? Okay. Now before we start learning about small vessel vasculitic conditions, we have to first understand some basics about ANCA, right? When we talk about SLE, I think first thing we have to understand is ANA, right? How do we evaluate ANA? I mean, how do we estimate ANA? What is the ideal method? What is the titer to call it as positive? Where it is falsely positive? Those things are important, right? So when we spoke about ANA in SLE, I think we were talking about the preferred method is indirect immunofluorescence, right? That is the gold standard for ANA estimation, right? But ANCA things get flipped here. So there we said ELISA is not routinely recommended. It is the indirect immunofluorescence that we were talking about when we talk about ANA, right? But when we talk about ANCA, the things get flipped here. So here the investigation of choice or a preferred modality of evaluation is ELISA, because ELISA not only helps us to identify this pattern of distribution of these antigens and antibodies, it helps us to specifically identify which antibody is produced. Like it helps us to identify the antibody against a specific antigen, right? So that is why ELISA is the investigation of choice. But as a screening tool, most often what we do is, instead of going for ELISA, we can go for immunofluorescence. Immunofluorescence is our screening tool, right? This immunofluorescence does not identify the antibody against a specific antigen. It just identifies a staining pattern, right? So based on the staining pattern, the ANCA are divided into cytoplasmic and perinuclear, right? So cytoplasmic is what we call as C ANCA, and perinuclear pattern of immunofluorescence is what we call as P ANCA, right? Okay, so what is C ANCA and where do we see it? C ANCA is where the immunofluorescence, if you do the screening test, immunofluorescence shows that the entire cytoplasm is smeared with immunofluorescent activity, right? Entire cytoplasm is smeared with immunofluorescent activity. C ANCA is usually due to, like, the antigen target for antibodies here is usually proteinase 3, right? Proteinase 3. So that means we have anti-proteinase 3 antibodies here, right? So we have anti-proteinase 3 antibodies in patients with C ANCA kind of or cytoplasmic immunofluorescence picture, right? Easy to remember. 3, proteinase 3 is what we're talking about, and C is the third letter in the alphabet. So that way you can remember, so that you don't get confused between P ANCA versus C ANCA, right? C is the third letter in the alphabet. It is targeting the proteinase 3, right? Okay. Now, what is the antigen target in patients with P ANCA positivity? So the P ANCA is targeting an antigen. The antigen is myeloperoxidase, MPO, myeloperoxidase, right? Again, pretty easy to remember. If given a choice, would you like to become the CM of a state, or would you like to become a PM of a country? If given a choice to me, I definitely want to replace Modi ji. Right? I want to be the PM of the country, right? So remember it here. P, myeloperoxidase, PM, right? CM is what we don't want to become. We want to become PM, right? So P ANCA, the antigen target here is myeloperoxidase. So this P ANCA is nothing but anti-MPO antibodies, right? C ANCA is anti-proteinase 3 antibodies, right? Clear? Okay. Majority of the ANCA associated vasculitic conditions are positive for P ANCA. Most of them, right? With an exception, which is our granulomatosis with polyangiitis, is where we start seeing C ANCA being a dominant ANCA. Otherwise, most of the other vasculitic conditions, we see P ANCA as the dominant thing. And particularly when we talk about P ANCA, we also talk about this thing called as atypical P ANCA positivity. Atypical P ANCA positivity or false P ANCA positive. Okay, so what is a false P ANCA positive condition? The classical example that comes to my mind is IBD, right? IBD is a condition where you might have P ANCA positivity, right? Okay. Now, what is this false positive or atypical P ANCA? Now, we are doing this P ANCA evaluation in 2 steps, right? So, we start screening with immunofluorescence. So, when we do immunofluorescence, we see this perinuclear pattern of immunofluorescence. Then we call it as P ANCA positivity. But when we do ELISA, right? In ELISA, we are trying to identify antibodies against MPO. So if the ELISA is negative, if there are no antibodies against MPO, so that means the antigenic target, though there is perinuclear distribution of these antigen antibody complexes, the antigen target is not myeloperoxidase but something else. In that case, we call it as atypical P ANCA, and a classical example for us to remember is inflammatory bowel disease. So in IBD, we see atypical P ANCA. In IBD, the target for the P ANCA is not myeloperoxidase. Clear? Okay. Now, if they give you images of fluorescent staining, you should be able to identify whether it is C ANCA or P ANCA. So as I have already told you, C ANCA means there is smearing of immunofluorescent activity on the entire cytoplasm, right? So you can appreciate here, the nucleus is not fluorescent, right? Nucleus is not fluorescent. We can clearly see this halo of the nuclei here and there, right? And we can clearly appreciate the cell border. The entire contour of the cell can be clearly appreciated, right? So this is very typical of C ANCA because the entire cytoplasm is smeared with the immunofluorescent activity. So because the cytoplasm is smeared with immunofluorescent activity, the cell outline can be clearly traced out, right? So you have a nucleus which is not fluorescent, and then your entire cytoplasm is fluorescent, right? So this is typical of C ANCA. In the next image, you can appreciate, like in this image, you can see that there is nucleus which is not stained, right? Nucleus which is not showing fluorescent activity, right? And just outside that, there is only a thin rim of fluorescent activity. So we cannot trace out the outline of the cell, right? So there is a thin rim of fluorescent activity. We cannot trace out the outline of the cell. This is what we call as P ANCA pattern. So these are the patterns on the immunofluorescent studies, right? Clear? So if there is an image given, you should be able to identify P ANCA and C ANCA, right? Okay. Now we will talk about these entities called as ANCA associated vasculitis. So when we talk about ANCA associated vasculitic conditions, what is the binding feature like common among all these three entities, the MPA, then GPA and EGPA? What is the common thing? The common thing is vasculitis. Now what kind of vasculitis we see here? So among all ANCA associated vasculitis, the vasculitis is characteristically described as necrotizing vasculitis. Necrotizing vasculitis, right? So there is necrotizing vasculitis often associated with fibrin thrombi formation. Fibrin thrombi formation. So we can call this as necrotizing vasculitis with fibrinoid necrosis, right? So that is the binding feature. So you talk about MPA, you talk about GPA, you talk about EGPA. All of these entities have this this necrotizing vasculitis with fibrin thrombi formation. This is the binding feature. Apart from that, there are additional involvement. So based on those additional involvements, we further classify these disorders, right? So to start a discussion, instead of starting with microscopic polyangiitis, let us start with granulomatosis with polyangiitis. That makes things little more clearer, right? So when we are talking about granulomatosis with polyangiitis, what are we talking about? We are talking about a patient who has necrotizing vasculitis with fibrin thrombi formation. Now this is predominantly affecting the small vessels, right? This is predominantly affecting the small vessels. Okay, what additional things we talk about? If you look at the name says granulomatosis, right? So apart from this, these patients have formation of granulomas, right? Now these granulomas are not only restricted to the vasculitic territories, they are also occurring in extravascular locations, right? So granulomas are in vessels in the vascular territory as well as extravascular. Now, what are the most common site for these extravascular granulomas? Whenever we talk about ANCA-associated vasculitis and we start talking about granuloma formation, we have to talk about the upper respiratory tract, lungs and kidneys. These are the three entities which are frequently affected, right? So every ANCA-associated vasculitis, we have to discuss about the involvement of upper respiratory tract, nose, sinuses and pharynx, and the ears, and we have to also talk about the involvement of lung, and we have to talk about the involvement of kidney, right? The least affected in terms of granulomatosis would be kidney, and the most affected is usually upper respiratory tract or the lungs, right? So when we are talking about granulomatosis with polyangiitis, we are talking about a patient who has small vessel vasculitis affecting the small vessel supplying major organs like kidneys, lungs, and there is a granuloma formation. This is the additional finding. The granuloma is affecting upper respiratory tract. Granuloma can occur in lungs, and that can lead to various clinical presentations, right? Okay. So we are talking about a patient who usually is 40 plus at the time of presentation. So most of these patients are in their 4th, 5th or 6th decade when they present with GPA. GPA males and females are equally affected, right? So there is no skewing of distribution when it comes to males and female involvement. Okay, so when we talk about GPA, we will be talking about involvement of important structures like upper respiratory tract, lungs and kidneys, right? So upper respiratory tract involvement in GPA can occur in various forms. The involvement is seen in 90 to 95% of the patients. That makes it the most commonly involved organ system in patients with GPA, right? Most commonly involved organ system. Now, when I am talking about 90 to 95% of these patients usually present with upper respiratory findings in the form of nasal blockade, okay, then nasal bleeding, crusting, okay, and we are also talking about some of these patients presenting with nasal septum perforation, right? Nasal septum perforation, and rarely this nasal septal involvement can lead to collapse of the bridge, leading to what we call as saddle nose, right? What we call as saddle nose. Now, this saddle nose is one point which can be asked as an MCQ, so do remember about it. Inside rheumatology, where we talk about saddle nose, we talk about saddle nose when we talk about granulomatosis with polyangiitis. We talk about saddle nose deformity when we talk about relapsing polychondritis, right? Relapsing polychondritis and our GPA are two conditions where we see saddle nose deformity, right? Where we see nose deformity in the form of saddle nose deformity, right? Clear? Okay. So this is seen in around 90 to 95% of the patients. Apart from this, there can be involvement of patients can present with otitis media and otitis externa. Otitis media and otitis externa can also occur, right? Apart from this, these patients are particularly at risk of developing subglottic stenosis. Subglottic stenosis, right? We have to remember this because if you talk about a small vessel vasculitis and subglottic stenosis, the first thing that should come to mind is GPA. And there is a second point I want you to note. In 2022, the 2021 recommendations have recommended the primary treatment modality of patients of GPA presenting with subglottic stenosis is not surgical dilatation. So that used to be the common practice for many years, but the 2021 recommendations from ACR recommends use of immunosuppression as the primary treatment modality when patient of GPA presents with subglottic stenosis. So only when the immunosuppression fails, then only we will be thinking of repeated surgical dilatation, right? Repeated instrumentation and dilatation. Clear? Okay. Now, the lung involvement is usually in the form of nodules. So, like we are talking about a granulomatous condition, right? So, lungs, we will start seeing granulomas. Now, upper respiratory tract, some of the manifestations were because of granuloma formation. So, we will also see granuloma formation in lungs. So, lungs, patients can present with nodules. And when we talk about nodules in the lungs, these nodules are mostly peripherally distributed. These are nodules which are peripherally distributed, right? So, sometimes they are like wedge shaped nodules with their pleura as their base, right? So, pleural surface as their base, and the wedge shaped, the peak or the triangular tip is directed towards the hilum, right? So, they are peripherally distributed usually, and these nodules have a tendency to cavitate. So, cavities can occur because we are talking about granulomas which can get into necrosis and then eventually lead to cavity formation, right? And because these nodules and cavity formation, often these cases are misdiagnosed as tuberculosis, right? So we should keep that in mind. Okay. Apart from that, these patients can also present with another presentation which is much more severe form associated with very high mortality, that is diffuse alveolar hemorrhage. These patients can present with diffuse alveolar hemorrhage. So we are talking about two kinds of presentation with respect to GPA: nodule formation and diffuse alveolar hemorrhage. Why I am saying two forms? Because when we talk about another condition called as microscopic polyangiitis, right, the next topic that we will be discussing, there is also lung involvement. So we will be talking about lung and kidney involvement, in fact, in all of the small vessel vasculitic conditions. So there the lung involvement will be in the form of diffuse alveolar hemorrhage. There we don't see patients developing nodules because in microscopic polyangiitis, as the name says, microscopic polyangiitis, there is no gross granuloma formation. These nodules and cavities are a result of granuloma formation, right? So because there is no granuloma formation in MPA, we don't see nodules. So only DAH is what we see there, right? Okay, now coming to the renal involvement in patients with granulomatosis with polyangiitis. Now the lung involvement is seen in around 90%, 85 to 90% of the patients. So 90 to 95% of the patients, upper respiratory tract is definitely involved. In 90 to 85 to 90% of the patients, we see lungs being involved, and in around 50 to 60% of the patients, we see renal involvement. So what is the usual renal involvement? The renal involvement is in the form of glomerulonephritis, right? Glomerulonephritis. The glomerulonephritis that we see here is typically in the form of segmental necrotizing glomerulonephritis. Segmental necrotizing glomerulonephritis. Okay. So how these patients will come to light? Now, if they have the upper respiratory tract involvement, they can present with all these upper respiratory manifestations, right? So nasal blockade, bleeding from the nose, the chronic sinusitis. Often these patients may also have, they can have recurrent staph aureus rhinosinusitis, right? Staph aureus rhinosinusitis. That is one more way of presentation, and that is with respect to upper respiratory tract. Now, the lung involvement, if it is diffuse alveolar hemorrhage, patients often present with respiratory failure, respiratory distress, and hemoptysis. And if it is nodular, they may be asymptomatic, and if they form cavities, these patients might even present with hemoptysis and cough, right? Cough, hemoptysis is a usual presentation. Now, the renal involvement, these patients will present with, like we're talking about glomerulonephritis, so these patients will present with hematuria. Hematuria, that is one finding. Then there can be proteinuria, right? So when we talk about proteinuria here is usually subnephrotic range, right? So we generally don't see nephrotic range proteinuria. Subnephrotic range proteinuria plus the hallmark of glomerulonephritis is what? Having RBC cast, right? So these patients will be presenting with hematuria, RBC cast, and subnephrotic range proteinuria, right? Particularly when you see a patient of 40 plus, right, and who has you upper respiratory tract findings, and you see lung nodules, the common tendency is to still think of tuberculosis, particularly in India, but it may be worthwhile just to get a urine routine done. So if the urine routine shows that there are hematuria present or there are RBC casts present, then maybe you can start rethinking about your diagnosis of tuberculosis in that case, right? Okay, so this is how a patient with GPA would present to us. Now, in this image, you can appreciate this classical saddle nose deformity. As I've already told you, inside rheumatology, there are two conditions I want you to remember for saddle nose deformity. One is GPA, the other one is relapsing polychondritis, right? Okay, in this image, you can appreciate the sinus thickening, right? Sinus thickening, which can be a CT manifestation of patients with GPA. And in this image, you can see there is a cavitating nodule. I've already told you that nodules are usually peripherally distributed, but inside rheumatology, there is nothing hard and fast. Cavities and nodules can occur centrally, but majority of the cases, they are distributed in the periphery, right? So remember that point. Okay. So now coming to the diagnosis of GPA, the first thing is high index of suspicion. Now the ACI 2022, it is classification criteria, so you're not duty bound to follow that for diagnosis, but generally it is generally believed that when you follow the classification criteria, you're likely to have a better sensitivity and specificity when it comes to diagnosis, apart from your clinical judgment, right? So in any patient where you are suspecting small vessel vasculitis, right, it is recommended that we should follow this classification criteria to classify the case as GPA, right? So what is the classification criteria says? In any patient where you are suspecting small vessel vasculitis, we have clinical criteria to look at and we have to laboratory criteria to look at. Now, okay, so this classification criteria in 2022 take a different approach. So what is the approach? There are some negative weightage given to findings which are like not typically encountered in that particular ANCA-associated vasculitis. For example, if I talk about peripheral eosinophilia, that is typical of EGPA. So if you see peripheral eosinophilia in a patient where you're suspecting GPA or in a patient where you're suspecting MPA, we will be giving some negative score to that. So just because there is eosinophilia, it doesn't rule out these conditions. So we will be giving some negative score to those points, right? Okay. So first, let us talk about the clinical criteria. Now, nasal involvement in the form of bloody discharge, ulcers, crusting, congestion, blockade, or septal defect or perforation, we are giving some points. Now, if there is a cartilage involvement causing saddle nose deformity, we are giving some point. And if the patient is having conductive or sensory neural hearing loss, we are giving some point, right? So patients with GPA can have both conductive hearing loss and sensory neural hearing loss. Sensory neural hearing loss is because of the vasculitis affecting the nerves, and the conductive hearing loss, as I have already told you, is because of otitis media. Otitis media is known to occur here, right? So we will be giving some points. So all these are suggestive of upper respiratory tract involvement, right? Now coming to the laboratory criteria, what are we looking at? We are looking at ANCA, because we are talking about ANCA-associated vasculitis. And as I have already told you, right, in patients with GPA, 75% of the patients are C-ANCA positive, right? This is only one ANCA-associated vasculitic condition where the C-ANCA is predominant form. In all other ANCA-associated vasculitic conditions, it is the P-ANCA which is predominant form, right? So another 20% of the patients are usually P-ANCA positive, and around 5 to 10% of the patients are ANCA negative, right? So even ANCA negativity doesn't rule out GPA, and ANCA positivity need not always mean GPA, right? Okay, so 20% can be P Anka, 75% can be C Anka. This is our basic understanding. So the current classification criteria says if the patient is positive for C Anka, then we will give a plus 5 points, because that is what is typically expected. But if the patient is positive for P Anka, then we will be giving some negative point. So P Anka positivity is seen in 20%, so it doesn't rule out, but P Anka positivity is more typical of the EGPA or MPA. That is why we are giving some negative point here, right? Okay. Apart from that, if there are pulmonary nodules, mass or cavitary lesion on the chest imaging, we are giving 2 points, because we are talking about granulomatous condition. So lung granulomas will go in favor of GPA over MPA, right? Then presence of granuloma, extravascular granulomatous inflammation or giant cell on biopsy. If you have taken the tissue biopsy, most common tissue biopsy site is either upper respiratory tract or lung. So on the tissue biopsy, if there are granulomas, extravascular granulomatous inflammation present apart from the vessels, or if there are giant cells on the biopsy, we are giving some positive points. And if there is inflammation, consolidation or effusion of the nasal, paranasal sinuses or mastoiditis on the imaging, like we saw the previous CT where there was sinusitis, so there we are giving some point. And if you have done the renal biopsy, if there is glomerulonephritis which is pauci-immune, that means there is no immune complex deposition, we will be giving some positive points, right? Okay, then the negative points, as I've already told you, are given for P Anka positivity, which is little not routinely seen in patients with the GPA. Only 20% of patients with GPA will have that. And if there is eosinophilia, right, eosinophil count more than 1000 per cubic microliters, in that case we will be giving a massive negative score of -4, right? Now all these parameters, there are 10 parameters. If the sum score is more than or equal to 5, we can classify the case as granulomatosis with polyangiitis. Okay, clear? So this is the classification criteria that we know. So let us now talk about the management of a patient with GPA, right? Now when we talk about management of ANCA associated vasculitis, right, regardless of what we are talking about, what specific entity we are talking about, there's a standard template of management. So these patients need to be treated with two-phase treatment, right? The first phase is induction regimen. So we have to induce remission. Induction of remission is our first stage. So we should know what is the preferred agent for a particular entity for inducement of remission. And once we have achieved the remission, maintenance regimen, right? Maintenance. So we should know what are the drugs that can be used for maintenance. Now, if you open most of the standard textbooks of medicine, the ANCA-associated vasculitic conditions management is grouped under one broad heading, and they generally say that management is usually in the form of induction. They recommend use of glucocorticoids, like usually high-dose glucocorticosteroids plus cyclophosphamide. This is what was being used for many years as a standard induction regimen. And for maintenance, we had a long list of drugs like methotrexate, we had rituximab, the anti-CD20 monoclonal antibody, rituximab, azathioprine, mycophenolate, mofetil, right? All these were considered as agents of choice for maintenance, including our glucocorticoids. But in 2021, the ACR revised its recommendation with respect to management of GPA, management of EGPA, as well as management of MPA, right? So we will be learning this updated information. This is very important, because if tomorrow you get a question where based on the clinical history and other parameters, you conclude that this is a question about GPA, and the question is asking what is the next best step in the management. Now you know that the patient has been diagnosed with GPA. We have to think of an induction regimen, right? So what is the induction regimen of choice? Given by the traditional approach, you would be going with glucocorticoid plus cyclophosphamide combination, but that would turn out to be wrong answer if we are talking about updation, right? So this is the algorithm given by the ACR in 2021, right? So this is the 2021 ACR recommendations for management of GPA. Now, if you look at this algorithm, you will notice that for severe GPA, the algorithm kind of combines your microscopic polyangiitis also, because most of the studies which were conducted on active severe GPA cases, the cohort was also a mixture of MPA patients. So MPA recommendation and active severe GPA recommendations are same, right? Okay, so the recommendations have a two flowcharts. One is for active severe severe GPA, right? Granulomatosis with polyangiitis, and active non-severe GPA. There is a separate recommendation for active non-severe GPA. So if a patient presents with active severe GPA, what is the induction regimen of choice, right? So induction agent of choice when patient is having active severe GPA is no longer we recommend use of cyclophosphamide, right? So the 2021 recommendation is in favor of rituximab. So if you're talking about a patient with granulomatosis with polyangiitis, where the currently patient is going through a severe disease and the disease is active, we will be inducing with rituximab, with or without glucocorticosteroids. Right? So glucocorticoids can be used. So if you look at this, the recommendation says glucocorticoids can be used. But again, if you're using glucocorticoids, the recommendation is a reduced dose, not the standard dose of glucocorticoids. So the mainstay of induction is rituximab. You can add a reduced dose of glucocorticoids to the regimen if you want. Right? And this is our induction regimen. Once you achieve the remission after using this induction regimen, once the remission is achieved, for maintenance, you can use rituximab. So if you're started with rituximab, maybe you can continue with rituximab for the maintenance. Or alternatively, you can use methotrexate or azathioprine or mycophenolate mofetil or leflunomide. This can be used as an alternative agent for maintenance of remission. Okay. If rituximab fails to achieve the remission, in that case, what we can do? In that case, we can think of adding we can switch over to cyclophosphamide. Okay. Again, please note here, the recommendation is to consider switch over, not combination, not combine the two agents. Like you started with rituximab, it is not helping. Don't just add cyclophosphamide. Take out the rituximab and add cyclophosphamide. That is going to be our approach, right? MCQ wise, mostly they will ask this: what is the agent of choice for induction of remission in patients with active severe GPA, right? Or in other words, in patients with MPA also. That is rituximab. Rituximab is favored over cyclophosphamide. This is the first point we are learning today. Okay. Now, if you are talking about a patient who is having GPA which is active but not very severe, in that case, what is our induction regimen of choice, right? So it is active but non-severe, right? If it is active but non-severe, our induction agent of choice is a combination. So here we are talking about combination, glucocorticoids plus methotrexate. This is preferred over every other combination that can be used. Glucocorticoids plus methotrexate. What alternative combinations that can be used? As the list mentions, glucocorticoids plus rituximab, glucocorticoids plus cyclophosphamide, glucocorticoids plus azathioprine, glucocorticoids plus mycophenolate mofetil, or even glucocorticoid alone can be used for induction of remission, right? In case of a non-severe GPA, active non-severe GPA, but the preferred agent is glucocorticoids plus methotrexate, right? So we have learned these two important MCQ points: active severe GPA, rituximab; right? Active non-severe GPA, GC plus MTX. The rituximab plus or minus GC in case of active severe, active non-severe GC plus methotrexate, right? Clear? Now with this regimen, if you achieve a remission, what is the next step? If you achieve a remission, you can try to maintain the remission with methotrexate, azathioprine or mycophenolate mofetil. Maybe you can just kick off the steroids and you can try to maintain them with the immunosuppressant agents, right? Now, if there is no remission achieved, what can we do? Again, the recommendation is switching to a different remission induction agent. Like this is the list of agents, so you can switch over to one of these agents. Like you started with the glucocorticoids plus methotrexate, you have not achieved the remission. Maybe you can think of switching over to a combination of GC plus rituximab, or a combination of GC plus azathioprine, or a combination of GC plus cyclophosphamide. That is our usual approach. Clear? So this is how we manage a case of granulomatosis with polyangiitis. Now, having understood this, let us go to the next vasculitic entity that we are talking about. That is our microscopic polyangiitis, right? Microscopic polyangiitis. So when we talk about microscopic polyangiitis, as we have already understood, when we talk about ANCA-associated vasculitis, we are talking about a necrotizing vasculitis with fibrin thrombi formation. So that will be standard template here, but here we don't see granuloma occurring, right? So microscopic polyangiitis means we are talking about necrotizing vasculitis without granuloma formation, right? When we talk about GPA, we are talking about necrotizing vasculitis plus granuloma formation. When we talk about EGPA, we are talking about necrotizing vasculitis plus granuloma plus eosinophilia, right? This is how we talk about EGPA, right? So coming to microscopic polyangiitis, here also most of the patients are 40 plus by the time of presentation, but there is a clear-cut male preponderance. So in case of GPA, males and females are equally affected. In case of microscopic polyangiitis, there is a clear-cut male preponderance. Most of them are 40 plus. The average age of presentation is around 57 years for microscopic polyangiitis. Okay. So how these patients present? These patients usually present with involvement of, so this is also a small vessel vasculitis, right? So these patients will present with involvement of kidneys and lungs, and certain additional organs, others, right? So what is the usual involvement of kidneys here? The usual involvement of kidney here is in the form of rapidly progressing glomerulonephritis. So these patients can present with RPGN, that is the usual renal involvement. Now what is the lung involvement? Here is where it differs from granulomatosis with polyangiitis. So the lung nodules that we were seeing, they were because of granuloma, right? So in GPA you can have lung nodules. You might have pulmonary infiltrates in patients with EGPA, but generally here we don't talk about nodules. So there are no nodules because there are no granulomas. There are no nodules. So only presentation is in the form of diffuse alveolar hemorrhage. So these patients can present with diffuse alveolar hemorrhage. Okay. The third thing in case of MPA is because there is small vessel vasculitis, the nerves are also affected. So these patients can present with mononeuritis multiplex. Mononeuritis multiplex. These patients can also present with aseptic meningitis. So most vasculitic conditions can present with aseptic meningitis. So just remember that. But mononeuritis multiplex, we are talking about two entities. One is GPA, the other one is MPA, right? Okay. So if you do the biopsy of the affected organ, right? If you do the biopsy of the kidneys, you will see RPGN. If you do the biopsy of the lungs, you might see there is diffuse alveolar hemorrhage, right? And there will be evidence of vasculitis. The vasculitis is devoid of granuloma formation. That is the key point that we need to know about microscopic polyangiitis. Now coming to its classification criteria. Again, the classification criteria was updated in 2022. And here also we have a similar approach, the clinical criteria and the laboratory imaging and biopsy criteria, right? So the first thing is a suspicion for a small vessel vasculitis is required, right? You are suspecting that the case is having a small vessel vasculitis, and other conditions which are essentially known to be mimickers of small vessel vasculitis have been ruled out, right? So we are talking about small vessel vasculitis, and other mimickers of small vessel vasculitis have been ruled out. In that case, we look at the clinical criteria. Okay. So in case of microscopic polyangiitis, as I have already told, there is kidney involvement, lung involvement, but I didn't talk about the upper respiratory tract involvement. When we were talking about the GPA, we were talking about upper respiratory tract involvement. In fact, I told that is the most commonly affected organ, right? So here there is no upper respiratory tract involvement. So if patient has manifestations of upper respiratory tract involvement, like there is bloody nasal discharge, ulcers, crusting, congestion, blockage, or septal defect or perforation, we are giving a negative score to the patient. Clear? So if at all there is upper respiratory tract involvement in patients with the MPA, it is extremely rare, and if it is involvement is there, it is usually mild, right? Mild in the form of recurrent staphylococcal, right, rhinosinusitis. Recurrent staphylococcal rhinosinusitis is what you might see, right? You don't see other forms of inflammation, you don't see granulomas occurring, you don't see septal perforation, you don't see saddle nose deformity in these patients, right? So -3 if there is upper respiratory tract involvement. Okay. Now coming to lab imaging and biopsy criteria. Now, as I've already told you, right, majority of the patients with ANCA-associated vasculitic conditions, apart from GPA, right, like EGPA and MPA, they are usually C-ANCA positive, right? So 70% of the patients with MPA are ANCA positive, and the predominant ANCA in these patients is P-ANCA, right? P-ANCA. So if there is a P-ANCA positivity, we are giving some solid positive points here, right? If there is a P-ANCA positivity, we are giving some solid positive points. Okay. Now, lung involvement in the form of fibrosis or interstitial lung disease on chest imaging, we are giving some points. We're not talking about nodules here. We're talking about fibrosis. We're talking about interstitial lung disease on chest imaging. We're not talking about nodules. So we'll be giving some positive points. Then in case of the biopsy, if there is pauci-immune glomerulonephritis, kidney involvement, we are giving some point, right? Okay. Now, if patient is C-ANCA positive, right, which is not typical, predominantly we will be seeing P-ANCA, so we have some negative scores assigned. And if there is eosinophilia present, more than 1000 per cubic millimeter, we will be giving some negative point, right? So if patient again here also accumulates more than or equal to 5 points, then we will classify the case as MPA, right? We will classify the case as microscopic polyangiitis. Clear? Okay. Now diagnosis I have already discussed in terms of classification. In terms of management, we have already discussed this point. So we will be managing most patients of microscopic polyangiitis as if we are managing a case of active severe GPA. So our induction agent of choice would be what? Our induction agent of choice would be rituximab plus or minus reduced dose glucocorticoids, right? And once we have achieved the remission, we can think of maintenance using rituximab, methotrexate, or azathioprine, or mycophenolate mofetil, or leflunomide. This can be used for maintenance regimen, right? And if we fail to achieve the remission using the rituximab plus or minus glucocorticoids, we can think of switching over to cyclophosphamide, right? So the same approach that we spoke about in management of severe GPA, active severe GPA, right? So that is about microscopic polyangiitis. Now talking about the next entity, that is our eosinophilic granulomatosis with polyangiitis. So when we talk about eosinophilic granulomatosis with polyangiitis, what are we talking about? EGPA patients generally have necrotizing vasculitis with fibrin thrombi formation, or what we call as fibrinoid necrosis, right? Plus we have granulomas. These granulomas, like the name says, eosinophilic granulomatosis. So these granulomas can be in vascular territory, like in the blood vessels, or extravascular, right? Extravascular generally airways and the lungs, where we will be seeing granuloma formation. Plus we are talking about eosinophilia, that means the peripheral eosinophilia is there, plus eosinophil infiltration of blood vessels and affected organ. Eosinophilic infiltration of blood vessels and affected organ. This is the typical discussion of EGPA, right? So this EGPA actually evolves. EGPA patients actually have a 3-phase evolution, right? There are 3 stages of evolution of EGPA. Okay, so the first stage is where patients usually present. We call this as a prodromal stage. So that is the first stage where patients usually present with atopy, allergy, and asthma, right? So there is a strong correlation between asthma and EGPA. We have to remember that. So when we talk about eosinophils, yes, asthma comes into picture, right? So first phase, patients only have manifestations of atopy, allergy, and asthma. So at this point of time, most of these patients are not diagnosed as having EGPA, right? Okay, so from there, they go on to the next stage, which is a eosinophilic stage, right? Eosinophilic stage. So in eosinophilic stage, peripheral eosinophilia becomes a predominant finding. Peripheral eosinophilia becomes the predominant finding. Okay, from there, patients move to the third stage, where vasculitis becomes manifest. So at this point of time, there is systemic vasculitis, right? So patients can have vasculitis, mainly the small vessel vasculitis, affecting kidneys, lungs, right? Affecting kidneys, lungs, brain, heart, right? All these structures can be affected. Even peripheral nerves can be affected, right? So because of the peripheral nerve involvement, these patients can also present with mononeuritis multiplex. These patients can also present with mononeuritis multiplex, right? So this is the usual presentation of a case of EGPA. Now when we talk about EGPA, we have to note that these are also usually P-ANCA positive. They are P-ANCA positive. P-ANCA positivity is seen in up to 50 to 60% of these patients. 50 to 60% of these patients. So in terms of ANCA positivity, the maximum positivity is what we see in patients with GP, and there it is usually C-ANCA positive. In case of MPA and EGPA, we see P-ANCA being the predominant form, right? So when we talk about classification criteria, we will be talking about giving some negative weightage if the patient is C-ANCA positive, right? Okay. Now, in terms of its diagnosis and classification, I think any patient who presents with small vessel vasculitic kind presentation and there is strong history of asthma or atopy, I think first thing that should be coming to our mind is EGPA, right? So the 2022 classification criteria again talks about the clinical and laboratory criteria. So here there is weightage given to presence of obstructive airway disease, because asthma has a strong correlation, right? So if patient has obstructive airway disease, we are giving some positive points. If there are nasal polyps, because we are talking about atopy, some of these patients can have nasal polyps, we are giving positive points. And if the patient is having mononeuritis multiplex, we are giving some positive point. Like the point to note here is that mononeuritis multiplex can also be seen in MPA, but there we are not ascribing any points there, but we are giving some points in the classification criteria for patients with eosinophilic granulomatosis with polyangiitis. Okay, so that is the clinical domain. Now talking about the laboratory domain, if there is eosinophilia, everywhere else we were giving negative points if there is eosinophilia. Now because we're talking about EGPA, we have to give positive points, right? So we're giving +5 points if there is eosinophil count more than 1000 per cubic microliters, right? Okay. Now if the C-ANCA is positive, we are giving negative score, right? If the C anchor is positive, we are giving negative score, right? Okay. Now, in terms of kidney involvement in patients with EGPA, it is usually associated with RPGN, right? RPGN, and these patients generally do not present with hematuria. These patients usually present with renal insufficiency. So because of that, we are giving some negative score if there is hematuria present, right? So hematuria should make us think of MPA or GPA more than EGPA. So there is some negative score given if there is hematuria present. And on this scoring system, score more than or equal to 6 is suggestive of EGPA, right? So we were talking about 5 when we spoke about GPA, and we were talking about 5 when we spoke about MPA. Here we are talking about a score of 6 or more than 6 to classify the case as EGPA, right? Okay, now having understood this classification criteria, let us talk about the management. So here also we will be talking about the 2021 ACR recommendations for management of EGPA. Now, this is also an ANCA associated vasculitis, so we will be talking about induction of remission and then maintenance of remission, right? So here also we will be talking about active severe EGPA. Here also we will be talking about non-severe active EGPA for achievement of remission. Once we achieve the remission, then we will be talking about further maintenance, right? So in case of active severe EGPA, the induction regimens that are recommended are either pulsed IV steroids, that is one approach that we can follow, or you can use high dose per oral glucocorticoids, that is the second approach, or third thing we can use is immunosuppressant agents like cyclophosphamide or rituximab. Okay, and here you are free to combine glucocorticoids plus cyclophosphamide or rituximab. That approach can also be followed, or you can just follow with the steroids or cyclophosphamide or rituximab. Now, once you achieve the remission, the maintenance depends on what agent you had chosen. For example, if you had achieved a remission on cyclophosphamide, the recommendation is to use methotrexate or azathioprine or mycophenolate mofetil for the maintenance of remission, right? That would be the approach. Okay, if patient develops a severe disease relapse after achieving the remission on cyclophosphamide or rituximab, what would be the maintenance agent? Like in that case, what would be our approach? We shouldn't be talking about maintenance because we are not at achieved remission. There is a relapse again, so we have to re-induce remission, right? The patient who had achieved remission with cyclophosphamide or rituximab, now we have to go for the reinduction regimen. Again, we will be talking about high dose pulsed IV or high dose oral glucocorticoids. Oral glucocorticoids are obviously on a daily basis plus rituximab, right? So if there is a relapse again, we have to go ahead with combination. So we cannot try only to achieve remission with repeating of the glucocorticoids or repeating with the rituximab alone, right? So we have to talk about using high dose daily glucocorticoids or pulsed IV plus rituximab. So we have to go with combination. So here we had an option, we could have given with a single agent approach to achieve the initial remission, right? And if you have achieved remission with rituximab, you can use rituximab for the maintenance, right? Okay, now talking about this active non-severe EGPA, there is one possible MCQ from here. If it is a case of active non-severe EGPA, what is the preferred induction regimen, right? The preferred induction regimen is a combination of glucocorticoid. So this is the MCQ point I want you to remember. Preferred induction regimen is a combination of glucocorticoids plus mepolizumab, right? So we have a place for mepolizumab in management of EGPA, and the 2021 guidelines recommend that don't use mepolizumab for induction of active severe EGPA. So in that case, only think of high dose glucocorticoids or think of cyclophosphamide or rituximab. But if it is a non-severe disease, you can bank on mepolizumab. So a combination of glucocorticoids plus mepolizumab is the preferred regimen, right? Clear? So this is our preferred regimen. GC plus MF is the preferred regimen. What is mepolizumab? It is the anti-IL-5 monoclonal antibody, right? Okay. Apart from that, you can use glucocorticoids plus methotrexate combination. You can use glucocorticoid plus azathioprine combination. You can use a combination of glucocorticoids plus mycophenolate mofetil. You can also use a combination of glucocorticoids plus rituximab. So this arrangement is in order of preference. So the first preferred agent is GC plus MEP. That is a preferred agent. And among this, probably the least preferred agent would be GC plus rituximab as the combination, right? In some selected subset of patients, we can use glucocorticoids alone for induction of remission, right? Once we achieve the remission, we can try to maintain the disease by eliminating glucocorticoids and try to maintain the disease with the agent that helped you in achieving the remission. For example, you started with mepolizumab and mepolizumab helped you achieve the remission. Maybe you can use mepolizumab for the maintenance. If you started with methotrexate and that helped you achieve the remission, you can maintain the disease with methotrexate. Same with case of azathioprine, same with case of mycophenolate mofetil, same with case of rituximab. What if there is a relapse after achieving the remission? If there is a non-severe relapse after achieving remission, if you achieve a severe relapse, like you achieved the remission and there is a severe relapse, you will be following this regimen, right? So you will be reinducing, and when we are reinducing for a severe relapse, we will be using a combination of steroids plus rituximab, right? If there is a non-severe relapse, the patient, if he was on mepolizumab or rituximab, in these cases, we have to think of alternative immunomodulatory drugs. But if the patient develops a non-severe relapse, having achieved or having been on methotrexate or azathioprine or mycophenolate mofetil or even glucocorticoid alone, any of these, methotrexate, aza or mycophenolate mofetil, any of these or glucocorticoids alone, in that case, I think the best approach would be to add mepolizumab, right? As such, that would have been our preferred agent. If you had not used it and you had achieved a remission with some other agent, right, and now patient has come back with relapse, the best thing would be to put the patient back on mepolizumab. And because we are talking about reinduction again, we will be considering glucocorticoids. So here we will be treating with a combination of glucocorticoids plus mepolizumab in a patient who relapsed after having achieved remission with the other agents other than mepolizumab, right? Okay, so that completes our discussion on management of EGPA. Now coming to the last topic for the day, that is cryoglobulinemia and cryoglobulinic vasculitis. What are cryoglobulins? Cryoglobulins are the immunoglobulins which are precipitated in the plasma on exposure to cold, right? So these are cold precipitated antibodies. Cold precipitated antibodies, that is what we call as cryoglobulins, right? So cryoglobulins occur in three types. There are three types of cryoglobulins: the type 1, type 2 and type 3. Okay, so when we talk about these types, right, we have to keep in mind when we talk about these types, these cryoglobulins are nothing but usually a mixture of IgM and IgG. So we should know whether this particular cocktail has IgM, which is monoclonal in origin, or whether it is polyclonal in origin, IgG, whether it is polyclonal in origin, whether it is present or not present, and if present, it is usually polyclonal in origin. And the third thing is this IgM that we see here, right? These IgM molecules often have a rheumatoid factor activity. So whether this IgM is RF factor activity positive or negative, those are the things we should know, so that we know these three types, right? So in type 1, it is only like we have monoclonal IgM or IgG present, right? There is monoclonal IgM or IgG present, and RF factor activity is usually negative. That means these patients have a monoclonal proliferation of IgM producing cells or IgG producing cells. So typically we're talking about either multiple myeloma, or we're talking about multiple myeloma or Waldenström macroglobulinemia, right? Waldenström macroglobulinemia is what we are talking about when we talk about type 1 cryoglobulinemia. So type 1 cryoglobulinemia is not usually associated with vasculitis, right? So in type 1, vasculitis is rare, right? All these clinical manifestations of these patients are usually because of hyperviscosity, right? So when we talk about multiple myeloma, most of the manifestations are related to hyperviscosity, not because of the vasculitis being triggered there. But type 2 and type 3 is where we see vasculitis. Okay, so what is type 2? Type 2 is where the cryoglobulins are comprising of monoclonal IgM plus polyclonal IgG. There is a combination of monoclonal IgM plus polyclonal IgG, right? So in these patients, this IgM has RF, rheumatoid factor positivity, right? So this IgM is RF positive and they have a polyclonal IgM. In type 3, what we see is they are having polyclonal IgM plus polyclonal IgG. Polyclonal IgM plus polyclonal IgG. Here also this IgM has RA factor positivity, right? So type 2 and type 3 we have RA factor positivity, right? Okay, so this type 2 and type 3 is what we recognize as mixed cryoglobulinemia, because there is a mixture of IgM and IgG which are polyclonal. In case of type 1, we only have monoclonal, so we don't call it as mixed cryoglobulinemia. Now, the causes for type 1 we have already discussed, that is MM and Waldenstrom. The type 2 and type 3 is typically seen in hepatitis B. It can be seen, hepatitis C. It can be seen in various other infections. It can also be seen in hepatitis B. It is not exclusive. The cryoglobulinemia is not exclusive to hepatitis C, but more than 80% of the patients are having hepatitis C, right? So they either have the type 2 or type 3 cryoglobulinemia. Among the type 2 and type 3, it is the type 2 which is most commonly seen in hep C patients, right? So that is about the cryoglobulinemic vasculitis. So with this, we will conclude our session. I wish all the best for your studies and preparation. If there are any doubts with respect to these update guidelines, please feel free to contact me on the PrepLadder NEET SS premium group on the Facebook.